Good morning. My name is Dr. Ernie Bowling. I am the editor emeritus of Optometry Times Journal, and I have the honor today to talk with Dr. Vin Dang, practicing optometrist in Bakersfield, California. Met Vin on several occasions, one of the young up and rising stars in our profession, and I appreciate you taking time out of your schedule to talk with me this morning.
I appreciate you.
Yeah. His practice covers a broad spectrum of ocular care with unique focus on ocular surface disease and dry eye. So that's an interest he and I both share. And we're going to talk about another one of his interests here in a minute that he and I share. Born and raised in Paris, France. Wow, okay. Immigrated to the United States at the age of 16, attended University of California, San Diego. Got a degree in biochemistry, which is not easy either. Got his degree in optometry, doctor of optometry from Southern California College of Optometry, and received his fellowship with the Academy in 2016. So another good organization. He's currently director of the Dry Eye Center at Empire Eye and Laser Center. He's established himself as a specialist in the areas of diagnosis and management of ocular surface disease, as well as providing advanced refractive eye care surgery, consultation care, and medical eye exams. In addition to practicing full scope optometry, Dr. Dang has contributed to several optometric journals, one of which we're going to talk about today, and presented lectures on incorporating ocular surface disease treatment and management into clinical practice. He serves on the advisory board of several eye care companies, assisting in the research and development of dry eye therapies and helping craft medical disease management issues. As any good optometrist would, he's a member of the American Optometric Association, the California Optometric Association, and current president of the Kern County Optometric Society. You're going to tell me how many members you got in that when we get done. In addition to his participation in organized optometry, he's also the residency coordinator of the Southern California College of Optometry, training the next batch of our best and brightest. In his spare time, which I doubt he has much of with two small children, he volunteers with one site to provide free eye exams to the underserved in his local community as well as internationally. He's trilingual, frequent in English, fluent in English, French, and Cantonese, and you're going to hit me with some of that before we get done too. And enjoys caring for patients of all ages and backgrounds. When he's not pursuing his passions, he travels the world with his wife and his two kids. In his spare time, he's always on the lookout he's a techno geek like I am, looking for the latest tech gadget, and spends his leisure time playing pickleball, the fastest growing sport in America, which is also a new love of mine. So that's, as I've gotten older, Vin, that's I can't play tennis like I once did. So I have to spend a lot of time on the pickleball court. I can cover it a little better. So I appreciate you taking time out of your schedule to be with us this morning. Thanks. I appreciate it.
Oh, thanks, Ernie, for the opportunity. You know, it's funny when I listen to my bio. I mean, it's just I have time to do all this stuff. It's crazy. It's, you know, just like some of my clinic manager would say, there's just not enough hours in the day to do all the things that we do. You know, I mean, it's really amazing how we are able to sort of prioritize our lives and things. So, but you know, I definitely appreciate you talking to me about just getting myself out there a little bit. So
there you go. We deserve it. So tell me a little bit about your practice. I know you're with the surgical co-management center. So tell me about what you do there and what your typical day is like there.
Absolutely. Yeah, absolutely. So at Empire Eye and Laser Center, we have 3 ophthalmologists. It's a corneal refractive, and mostly an anterior seg practice. So corneal refractive, oculoplastics, and the general ophthalmologist. They're actually brothers. And one of the brothers has been, one of his career goals has been to, as he said, is to conquer presbyopia. Right. So I told him that was a really lofty goal. I'm glad I'm on this journey with him because it allows him to sort of push the envelope, in terms of we do a lot of clinical trials for next gen IOLs. It allows me to just basically practice to the next level, to full scope optometry. When I was first hired almost 13 years ago, he came to me and said, hey, we've had optometrists working in our practice before, but they've always been in the capacity of refractions. they do all the VSP exams, comprehensive care with contact lenses exams, things like that. But he actually did his fellowship at in Minnesota under Dick Lindstrom,
Oh,
right? So
yeah.
then he worked very closely with the fellows, the optometry fellow, the corneal fellow, right? So then he knew the setting where it was optometrists, ophthalmologists working together. So then he said, okay, well, I want you to kind of come and work at my practice and do the same thing. I want my optometrist to be, the primary eye care, take care of the patients, not just do routine care. I want you to do the pre-op, the perioperative management. I want you to, see all the glaucoma, all the mac degen patients, diabetic, all that stuff. I want you to take care of this. I want to focus on surgery. And that's that was very, very appealing to me because at the time I was working in retail. So I was working at a lens crafter, so just basic type of exams. So being able to switch over to medical eye care, which was sort of my dream, I started being sort of the gatekeeper at the practice, right? So I said, I want to be able to see everything and anything and everything, right? So if there's any type of referral, I want to be able to see that patient first, and then I want to be able to funnel that patient to wherever they need to go. If they need to have any type of surgical consult, whether it be for eyelids, then they go see the plastic surgeon. If they need to have cataract surgery, then I funnel them to the cataract surgeon. So I did that for the first 2 years as I was, developing my craft, and then slowly I started getting more and more interest into ocular surface disease, dry eye disease, because I personally suffer from that.
As do I.
Yeah, so it was a big passion of mine because I wanted to make sure a lot of these patients, don't suffer the same fate that I was, me being fairly young, and suffering from, MGD and not having much luck with the, treatment therapies out there. I was like, well, there's got to be, better things out there. And that's when I started, doing more with some of the companies, so that way I could be at the forefront, right? So he was sort of my mentor, because I saw how he was involved with industry, and how he able to learn about new technologies and new products. I wanted to do that also, but in the dry eye space, so to speak. Now I'm the like you said, I'm the dry eye clinic director, and my clinic day looks like about 70 to 80% of my patients now are strictly dry eye patients. I got internal referrals from the ODs and the MDs, but I also get outside referrals for dry eye evaluations from patients from all over town and all over the state, actually. So
Good.
and I enjoy that. It's great because I'm able to help them.
And you got all the bells and whistles there, the IPL and the Lippy Blue
I
Review.
try to, yeah. I mean, we didn't first start having all of the bells and the whistles, but I mean, it's funny because a lot of the colleagues will always ask me, okay, so I mean, you're a dry eye guy, and so how do I become a dry eye guy? How do I start my own dry eye center of excellence? And it doesn't take much. I mean, I say, you start out with what you have in your drawer, right? I mean, by staining, do tear breakup time, use your slit lamp skills and evaluate the cornea, look at the lid margins and things like that. But I mean, obviously over time we've required more diagnostics. So we have a lipid scan, we have a LipiFlow, we also have the tear care. We have an IPL, we have a BlephX, so those are all of the sort of tools that we have to help us treat, ocular surface.
Busy man, busy day. So tell me then, with the COVID outbreak, the plague, whatever you want to call it, How has that changed your way of doing things? What, I guess, procedures, what precautions are you taking within y'all's practice, because you're obviously a high volume practice, to protect yourself, protect your staff, and your patients?
Yeah, so thankfully for us, before we started all of this, we had started implementing this protocol that's called Six Sigma, Lean Six Sigma. Yeah, so what this protocol does is basically it improves processes all throughout the practices to make you more efficient. One key point that we were looking at was patient wait times, right? So a lot of patients, even though they love the care that they were getting at our practice, were complaining about, wait times, sometimes having to wait, an hour, sometimes an hour and a half, or even being in the practice for, sometimes like, 2 hours, right? So our clinic manager, was able to identify key areas in our practice and say, okay, well, this is where our patients are bottlenecking. It's like we're running out of room. A lot of our technicians are waiting around before they're able to take a patient back because there's not enough space. So then we implemented this, what we call the lean schedule. So the lean schedule allows us to, stagger patients, make sure that certain diagnostic tests are not double booked. We've developed different appointment slots, and we're very strict. So we now have short, medium, and long slots. And then so she, during her evaluation, she timed each of the different appointment types. So if cataract consultation, will be a long slot because you be in there and you got to talk to them, explain to them the different options. A dry evaluation is a long one also, but like a routine once a year dilated exam is a short one, right? So those are like 5 minutes. So then that helped us quite a bit. Obviously we do all the same things that everyone else is. In the beginning we've had everybody call the office before they come. We would meet them at the front door, and we would do a temperature check, ask them all the COVID questions before we let them in. But what happens is here in Bakersfield, it's very, very hot, right? I mean, we're this weekend we're expecting a heat wave. It's going to be 107. So that got to be an issue with us having patients waiting in the car because even with the car running, I mean the temperature we would get false, exactly. It would be very, very hot, right?
Yep.
And as soon as they came in, we let them cool down for 5 minutes. We recheck the temperature, and the temperature would go down. So then, probably about a month ago, we started saying, okay, well, why don't you, come in? You no longer have to call to check in. You can actually come to the door. We'll check your temperature at the door, and then we bring them right back. So we started sort of limited the amount of patients in our reception area. So we have a fairly large reception area. So we implement obviously all the social distancing. There's no more than 3 patients at a time. Because the thing is, even though our practice is pretty large, at any given point we can have 5 or 6 providers, right? So that's and what we've done was stagger the arrival time too, right? So it's like we'll have a patient arrive at 9, and another patient arrive at 9:05, another patient at 9:10. And one thing too is that we've been very, very strict with arrival time, right? So like the grace period, before it was sort of like, okay, yeah, we'll take you in, sure, we'll take you in. Now it's like, okay, if you're 5 minutes late, that's going to impact the whole schedule, right? Because that's 2 people there, and that's gonna
do it.
So we can't do it. So now we're very strict with our arrival time and grace period. So if they're late,
that's a lot of our patients. I'm the same way. It's like you're not here, because of what we have to do, what the changes that we've had to make. You're throwing us behind, and I don't want a bunch of people in the waiting room either. So I reschedule, and of course there's you irritate them that way too sometimes, and the mask thing irritates them too. But it's the way
Absolutely.
things are right now. It's just the time
Exactly.
we live in, and it's what we have to do. I'm sure you wearing the mask and the gloves and the shields and all that. And I tell my patients when they complain about having to wear a mask, it's like, look, you think I want to wear all this stuff? I mean, come on. But it's what we have to do right now to maintain safety and be able to maintain and take care of our patients, because I don't want to put myself at any great risk either. Because just like you got two small kids, I got a new grandkid. I want to be able to, see him and spend time with him and things like that.
Yeah. Well, I just don't want to be I just don't want to be in quarantine for 14 days.
There you go. Yeah. We did that when that first happened. I told Gretchen Bailey, it's like,
Oh,
she said, what have you learned? I said, I've learned I can't retire, and I've learned I'm not cut out for
no.
this. I just can't do
Yeah.
it.
So we shut down for about a month, and I played stay-at-home dad for about a month, and as much as I enjoyed being with the kids, it just made me realize that I can't, trying to do homework, trying to cook and clean is just, by the time I was done cooking and cleaning and doing with the homework, the cycle had to start all over again. And it made me realize like, I miss, my cleaning lady, and we would order takeout. It was a nightmare.
That's good. You recently wrote an article for Optometry Times about pre-authorizations for dry eye or any medication, really, but I know the specific focus was on the dry eye products. So, and it was an excellent piece. I really learned a lot from it, but I wanted to give you an opportunity here to talk about that, because it is a real problem in practice, no matter where you are. That prior authorizations are just a fact of life, but they're a pain in the keister too. So, how have you managed to walk that maze or make that maze work for you?
Yeah. So, in my article, I talk about this thing called, PA fatigue, and it's real. A lot of practices, thankfully, I'm in a big enough practice where I have a, a staff member that's able to kind of help me. She's sort of my go-to person, right? So what we've done with our practice, we've sort of assigned one person where we say, okay, so she kind of does multiple things. But her, whenever I have any issue with, okay, I need something to be done in terms of like answering more questions with, prior authorization, she's sort of our go-to person to do it. But it's a real problem, right? I mean, that these insurance companies are just making our lives that much more difficult, right? They, at the end of the day, they're a business also, right? I mean, they want to just make it as hard as possible to not have to pay out things, and so they make you jump through all these hoops. But the simple thing is just you just have to document, right? I mean, a lot of the doctors don't realize that just you have to. It's just like what they teach us in school, right? If you didn't document it, then you didn't do it,
Right.
right? So that's the same thing, right? So if you want to be able to get a prior authorization approved, you got to document that patients have done artificial tears, do some of the diagnostic tests, right? So some of the simple things that we had talked about, like vital dye staining or tear breakup time, so those are the simple things that they will always sort of ask for, right? So have they been on some form of artificial tears? They tried a couple, or is there actual signs of dry eye, right? So then on all of my dry eye patients, I always make sure that, I always tell my technicians, it's just like, you cannot put down, generic artificial tears. You have to specifically write down, ask the patient, okay, which type of artificial tear you use, and then write that down, because, down the road, there's always going to be, some form of, I always keep it in the back of my mind where I'm always going to have to potentially fill out some, prior authorization paperwork, right? So then if I don't have that information, that makes it that much harder for me to, to help the patient. But, I also tell the patient too, I say, hey, it's just, I want to help you, but your insurance is making it real difficult for me. So then I tell them, just call your insurance and say, hey, my doctor wants me to take this medication. You keep denying it. What's going on, right? So I put the onus on them too, to just say, hey, call your insurance and complain, because that's the insurance company is gonna get more phone calls. They're gonna notice some things too. So, and I'm hoping that kind of helps move the needle a little bit.
I think it does. I think it's if insurance company hears from the patient, who is also the customer who pays that premium, that they're going to be a little more likely to, pay a little more attention. That, especially again, volume, the numbers, the more people that call, the faster that needle will move. I agree with you. I really do. I know that you have a dry eye specialty clinic, and that you're very, specific, very practice at a very high level. One of the things I wanted to ask you, and just came through my mind, is how do you, what do you do for a patient who has a neurotrophic keratitis or a neurotrophic dry eye? How do you treat, how is that different from just your routine run of the mill dry eye? Because those patients, the ones that give me, that I probably lose sleep over, because it seems like everything I've done for them really just doesn't, move the needle. They're still in pain. They're still having trouble. So give me some pointers here about how to handle these really, really cases that you've thrown the kitchen sink at, but you can't,
Sure.
be doing anything for.
Yeah, absolutely. So, so thankfully we have this new medication that just kind of came to market in the past year and a half or so, and it's called Oxervate. So, I'm not sure if you heard about it, but Oxervate is, recombinant nerve growth factor. That's been very helpful. Um, it's the same thing too, right? So the new medication is very, very difficult to get it approved and things like that. But thankfully, the company Downpay has done a kind of a good job of assigning, a special third-party company to help you get that process going, get it approved much easier. For the neurotrophic keratitis, you have to remember to it's the same thing, right? So in order to get this new medication approved, you gotta do some testing, and that testing is corneal sensitivity, right? So, but the problem is because it's so new, there's not a lot of things out there, right? So unless you have, you're in sort of a academic setting or research setting, you're not going to have that aesthesiometer, right? I mean, that's the real tool that they use to actually measure corneal sensitivity, right? So a lot of the doctors out there, have talked about some different methods of measuring corneal sensitivity that's readily available in your practice. So the con wisp, so you basically use a Q-tip, and then you just kind of pull the Q-tip until you get sort of a wisp, and then you kind of try to do that. There's the dental floss method. So you just grab some dental floss, and the same thing, kind of you touch that, and that's how you're able to kind of measure the corneal sensitivity and document the corneal sensitivity. And then if they've got any sort of reduced corneal sensitivity, then you can officially diagnose them with neurotrophic keratitis. And then at that point, if you've tried obviously all of the amniotic membranes and autologous serum, and it's nothing makes them any better, then at that point, then you can talk about putting them on Oxervate, which is this new medication.
So a lot more hand holding with those patients in my practice.
Absolutely.
Yeah. Because they're just everything they've been to every doctor there is, and they've tried everything there is, and they're just bless their hearts, there's just no relief.
Yeah, and it's one thing that we didn't talk about too, is that not only sometimes some of these patients don't not only suffer from the the neurotrophic component, but they also suffer from the other pain issues, right? So it's not just central nervous pain; it could also be peripheral pain too. So, and I actually just saw a patient yesterday, right? I mean, she suffers from multiple issues, from fibromyalgia to Sjogren's, and she always talks about how she's got chronic dry eye pain, right? But then when I talk to her in the details, I say, well, I'll be able to treat your dry eye pain, but then you're talking about how your eye aches all of the time, how you feel like behind and in and around your eye, you've got this, aching feeling and things like that. Well, and that to me, that we did the Preparicane test, right? So we numbed her eye, and then she said, "Oh yeah, my eyes feel better, but I still feel this pain." And I'm like, "Well, there it is, right there. I mean, I will be able to help you with your dry eye pain that you're calling, but that sensation, that pain feeling that you get in and around your eye, that pressure, that's something else. That's something that you're going to have to work with your pain specialist, right?
I was
To
going to
be
ask
able
you,
to
you send them to a pain specialist for gabapentin or some other type of medication.
exactly.
From their office.
Yep.
All right, fair enough. Let's just a few minutes left. I really want. I can't let you go without talking about pickleball, man. You know, we were on the phone or talking a few days ago. We were talking about it. Singles or doubles? Which one do you like to play?
You know, if I want a real workout, then I'll go in and play some singles. But it's, you know, now that it's getting so hot, it's very difficult for me to get into playing, you know, singles. But you know, I love playing doubles. It's more fun. You know, you get you know, a group of people, and you know, just it's a social playing. You know, so thankfully, even during these times, you know, the kitchen line, which is, you know, that line between the net, is far enough where, you know, you don't have to worry too much about
social distancing there, man. 7 foot from the net to the kitchen, so you know you're 14 foot. You're good. That's exactly. Yeah.
So it's just been fun. I mean, I actually when I was younger, I used to play. When I was in France, I was part of a table tennis club. And I learned playing table tennis when I was in France, and you know, when I came to the States. So, you know, believe it or not, even though, you know, I'm real tall, you know, a lot of patients always ask me, you know, patients and colleagues, you know, it's like, oh my God, you're so tall, you're 6'5". Did you play basketball at any point? And you know, and I always tell them, you know, and not really, you know, and I'll tell them that I used to play table tennis, and they're like, oh my God, table tennis, that's you know, how. So it was a nice transition from, you know, table tennis to pickleball, because you know, it's very similar. It's just much bigger scale, right? You know, a little bit of a bigger paddle, a little bit of a bigger ball. I like the fast pace that we play. That's, you know, kind of reminds me of when we play table tennis. It's super fast paced. So I enjoy very much. We play, you know, about once a week or so, and my wife kind of gives me the leeway to do that about once a week, which is always great.
Fastest growing sport in America, like I said.
Yes, it's great. It's just a fun sport. I mean, all the patients, all the, you know, all my friends and even patients that I've sort of, you know, talked to them about, you know, they've always said, oh my God, it's such a fun sport, you know, and just like you said, you know, it's an easy transition too. A lot of people here in Bakersfield, you know, play a lot of tennis, you know. And just like you said, you know, it's harder when you get a little bit older to just kind of move around, but you still want to stay active. And pickleball is a nice, easy transition into that.
Yes. Well, I know you got to go see patients because we're on a different time zone. I appreciate you taking time, Ben, to talk with me this morning, and I hope we'll get a chance to do it again a little bit later. But best to you, and keep safe. Okay.
Absolutely. You stay safe as well.
Appreciate you. Later. Bye bye.